But I am excited to introduce our first speaker. Anna is here, who is currently working in her Master of Social Work program. She is interning at the Michigan Parkinson's Foundation. We're so lucky and fortunate to have her. Her passion is definitely in the veteran community. That is her primary focus. And I hope you really pay attention to this program. Like we had the opportunity to see her program, and you don't even need to be a veteran to appreciate her work. But with that being said, I am happy to introduce Anna, and take it away.
Is my audio okay? Is it a little too loud? I don't want to lecture anybody and have them leaving with a headache. So thank you to Julia for the opportunity to speak today, and thank you to Michigan Parkinson Foundation for the opportunity to come and talk about veteran mental health, which is the clinical focus of my Masters of Social Work program. And so to kind of give you a roadmap of where we're going, the first third, I'm going to talk a little bit about the specific program that I'm in through Michigan State, which is the only Masters of Social Work program in the country that directly deals with veteran mental health when it comes to combat veterans. There's a few other programs that deal with just general military culture, but this is the only program that's specifically addressing combat veterans and their unique mental health needs. In the second two-thirds, I'm going to be talking about veteran mental health and specifically the things that have been lacking when it comes to veteran mental health and that have led to the devastating numbers that we've seen when it comes to the veteran community and poor mental health outcomes. And then after that, Dr. Leventhal is going to have a presentation that's going to talk a little bit more about Parkinson's and the support that you're able to access through the VA. So a little bit of a background on myself. I got my bachelor's degree from Michigan State in psychology. I had additional training in forensic psychology in Canterbury, England. My clinical focus, as I said right now, in my Master's of Social Work program is combat veterans. And my long-term goal is to become a mental health clinician working specifically with our veterans, especially combat veterans with their unique needs. So this is a certificate program that I'm in through Michigan State. As I said, it's the only one in the country that deals with this unique topic. It uses two classes, one that I finished in the fall and one that I'm wrapping up right now in the spring. And I'm going to talk a little bit more about the classes, but again, this set of courses, as well as the clinical exposure that we're given in our second internship, typically through the VA, is to enable us to become the most culturally informed social workers that we can for this population. And so when I first started my program, I was actually going to work with sexual abuse survivors. That's what I thought I was going to go into. And at the very last minute at my orientation, the woman who's in charge of the combat veteran certificate came up and she told a story. She told a story of her husband who had served in Iraq and had come home, had pretty severe mental health challenges for a few years when she eventually encouraged him to go seek help at the VA. The social worker there asked him some questions about himself. He said how he was a Marine, he had gone and served in Iraq, he was having some problems now. And she said, "Thank you for your service as a soldier." And when I heard this story, I started looking around the room. I didn't really see a problem with what she had said. I was questioning why he would quit his treatment because of what she had said. I thought maybe she shouldn't have brought his service up that quickly. Maybe that was the problem. Before she shared that he wasn't a soldier, he was a Marine, and that was important. That ignorance spoke volumes of the type of mental health treatment that was being offered. And so it's pivotal in our treatment, in our program rather, that we learn about the military, that we learn about the experience of our veterans so that we can have a more compassionate, empathetic, and informed understanding. So the first class that I took was in the fall, and it is by far the hardest class I've ever taken in my life, far past neuroscience or anything I did in my undergrad, primarily because of the war footage, primarily because of the veteran testimonies, primarily because of the stories of suicide that I heard. And this class used a storytelling approach that took us from enlistment to boot camp to pre-deployment to war to post-deployment struggles, using a mix of veteran testimony, real-life footage, and pictures that I can still see when I close my eyes. And all of this was used to give us a more thorough understanding so that we don't have that same approach that that social worker had with her husband. And in the second class, which I'm wrapping up right now, we're learning a little bit more about the clinical side of things. Where are our weaknesses? What are we not treating? Why are the numbers where they are? And through doing so, we're able to learn the newest techniques that we can bring into mental health treatment that will more thoroughly address the struggles of our veterans. And so during this time, I've had the unique privilege of interning at the Michigan Parkinson Foundation, where I've learned so much about the connection between Parkinson's and our veterans, learning why so many veterans have Parkinson's, having the unique privilege of being able to talk one-on-one with veterans and hearing their stories, which has provided me with so much invaluable knowledge as I go forward. So I'm not going to talk about this too much in depth, but there's a number of different ways that I've learned about ways that our veterans are at an increased risk for Parkinson's. So this can be due to chemical exposures, things like Agent Orange and other herbicides used, airborne exposures, more common in Iraq and Afghanistan, with burn pits that were used to get rid of waste right next to a military base where our troops were stationed. As Nate shared in his story, the water contamination at Camp Lejeune and other locations, as well as traumatic brain injuries that are incredibly common because of combat. And all of this leads to an 80% increased risk for the development of Parkinson's compared to the general population. While I've been at the Michigan Parkinson Foundation, I've been able to develop educational programming for our staff and board to equip our staff to be more trained to deliver respectful and culturally informed care when it comes to our veterans. So this is some of the programming I've developed and been able to share with the staff. And so now I'm going to transition into talking about veteran mental health. I do want to give a general warning that while I try not to be overly gratuitous, there is discussions of combat trauma, sexual abuse, and other content that might be found that might be upsetting. I advise anyone to put their mental health before anything I have to say. So this is one of my biggest inspirations for the work that I do, and I like to share his story whenever I have the chance. This is Willie Wold. His lifetime ambition was to join the Marine Corps. He took extra classes when he was in high school so he could graduate early and enlist at only 17 years old. He guarded President Bush for a few years before being deployed to a tour in Fallujah in Iraq. And upon returning home, he had numerous struggles with post-traumatic stress and chronic pain and other injuries and complications due to his time in combat. And unfortunately, Willie Wold passed away only 2 years after returning home. He accidentally overdosed on a cocktail of medication that he was prescribed at the VA for all of his different problems after a night of drinking, and his friends found him when they were going to take him to go camping the next morning. He was only 23 years old, and when I think about the work that I'm doing, I think about Willie Wold and all of the veterans who have unnecessarily died and suffered because of poor mental health treatment. So there's a myriad of different problems that our veterans experience, things that are psychological, physical, societal, and all of these things interact with each other and can worsen existing problems. So on the physical side of things, we see things like chronic pain, which impacts around 2/3 of our veterans, traumatic brain injury, around 67%, societal problems like incarceration and homelessness, around 13% of our adult homeless population is comprised of veterans. Mental health problems like moral injury and post-traumatic stress, substance abuse, all of these things interact with each other and exacerbate them. And when we're not able to approach all of these problems, we leave holes missing in our treatment. And so this is a number that when I first read it, I had to read it a few times. So I'm going to let us all have a little bit of space with it. Since 9/11, around 7,000 American troops have died in combat. And in that same period of time, 150,000 veterans have died by suicide. If you want to see that on a chart, that's what it looks like. The orange being how many veterans that have died by suicide, and the blue being those that have died in combat. When we think about veterans dying, we think about guns and IEDs, but the reality is most veterans are dying when they're back home. There's number of different factors that can increase the risk for suicide, some a little bit more apparent than others. Combat exposure, certain traumas like military sexual trauma can increase this risk, while some aren't as well known. Unfortunately, our youngest veterans are our most at risk. Those that have recently left the military within the past year are the most at risk. Those that had a dishonorable discharge status, most at risk. And so when we approach the idea of suicide in the veteran community, we need to be informed as to what veterans are most at risk so we can provide adequate treatment and prevention strategies. But it is always important to remember that suicide is not the story for most veterans. Post-traumatic stress disorder is not the story for most veterans. Any of the problems that I've talked about are not the story for most veterans. You should never generalize or pathologize the veteran experience. Veterans are not defined by suicide or by any of their mental health challenges. They are defined by their service to this country. And so now I want to transition into talking about what we believe in my program to be the missing puzzle piece when it comes to veteran mental health. And can I ask, I know we have a smaller crowd in person, can I ask for a show of hands, who has heard of moral injury before? And who had heard of moral injury before hearing me talk about it in the past few months? Well, I just wanted to put us all on a fair playing field, but moral injury is something I had never heard about after years of studying psychology, and something that's only been recently introduced to me in this program that I'm in. And so moral injury is the injury that occurs to somebody's psyche and conscience when they see, perpetuate, or fail to prevent something that violates their deepest held moral beliefs. This is a trauma that isn't necessarily about fear or panic or nightmares or flashbacks. This is something that happens when someone sees the worst of humanity, is forced to participate in it, or can't prevent it. Moral injury is something that can impact anybody, but is especially prevalent in combat veterans because war is hell, and war provides a whole hell of a lot of opportunities for moral injury to occur. So again, there's a number of different ways that moral injury can occur. Take, for example, a medic who's not able to save someone's life. Take, for instance, someone who has to drop a bomb knowing that civilians will die in that blast. Someone who has a best friend die. Someone who experiences military sexual abuse and the person who did it gets away with it. Moral injury might sound like, if I was capable of doing that, what kind of person am I? Or the military swore they would take care of us, and they didn't. Or even, if God lets things like this happen, is my religion even true? Moral injury is an existential threat to what we hold on to as human beings. So moral injury can take a few different forms. Transgressions by self, meaning something that an individual had to do, maybe accidentally or being forced to kill a civilian, having to leave somebody behind, something like that. Transgressions by others, meaning seeing somebody else do that sort of thing. Or betrayal, being maybe being given orders that are considered immoral by a commanding officer, not receiving adequate support from the military, something like that. And so sometimes there can be a little bit of hesitancy with the idea of moral injury. Are you saying the military is immoral? Are you saying that military personnel is immoral? Absolutely not. As the combat psychologist William Nash said, it's the fact that our service members have such high moral standards that leaves them way more vulnerable to moral injury. They have these high standards. They've been trained to meet these high standards. And so they're more susceptible than I might be, than other civilians might be to moral injury, as well as being put into situations that are more likely to produce moral injury, not due to any personal failing, not even due to the military's failing necessarily, but due to the failings of humanity in times of war. And so when you think about veteran mental health, you usually think of post-traumatic stress disorder. That's the big thing that pops into people's minds. This is somebody having flashbacks, nightmares, reliving a scary situation, a life or death situation that they can't move past for whatever reason. And while this is very real and it impacts up to 20% of combat veterans, it is very distinct and different from moral injury. There are some overlapping symptoms like substance abuse, anger, nightmares, things like that. But they are two distinct conditions that come with different symptomologies. So with post-traumatic stress disorder, again, we see those flashbacks, we see hypervigilance, reliving events, whereas moral injury, we see guilt, shame, feeling alienated from their comrades, maybe from the military, from society, from their previously held moral beliefs. And so this isn't just kind of like a definition thing. This isn't something that we've just come up with. This is a physiological reality that results in different changes in the brain. So when we look at the brain of someone with post-traumatic stress disorder, we see a ton of activity in the amygdala. And the amygdala helps to release adrenaline when we need to enter into a fight or flight state. If someone comes at me with a gun, I sure hope my amygdala lights up and gets my body ready to run, fight, freeze, whatever that needs to be. Whereas with moral injury, we see hyperactivity in the precuneus. And what the precuneus is, it deals with self-referential processing. And it's a really fancy word to mean how we view ourselves in relation to the rest of the world. This is a completely different part of the brain. And when we look at these two different traumas in brain scans, they show up differently. This is not just somebody having a hard time letting things go. This is a real change that's happening in the brain. This is like a computer being on overdrive in a specific region. And so we have really great treatments for treating post-traumatic stress disorder. They are highly effective: prolonged exposure therapy, cognitive processing therapy, and these are usually developed using civilian populations that have experienced rape or child abuse. That's usually the population that these therapies have been developed from. And unfortunately, these therapies are completely ineffective with treating moral injury. In fact, these therapies that are often used as the gold star treatment for our veterans can exacerbate the symptoms of moral injury, forcing someone to relive a morally injurious event that they haven't been able to process and heal from. Thankfully, fairly recently and currently in develop, we have new therapies that are being developed to treat moral injury in particular. And these don't look like the existing therapies because they're not for the same condition. We wouldn't give insulin to somebody with cancer, right? We need a completely different therapy that's going to address the underlying mechanisms behind moral injury. And even more so than treating, it's for healing. Because there's no disorder really with moral injury. If any of us are forced to kill a civilian, that should maybe stick with us, right? That's not a disorder. That's not something that's wrong with you. That's something that needs healing. And so these different treatments are able to offer that healing. Some have been peer reviewed, like the two on the top, and then one is still under review. But the hope is that with more awareness, we'll be able to get the support to get these therapies going and more readily accessible. I'm now going to switch to talking about adverse childhood experiences, which is another big missing puzzle piece when it comes to veteran mental health. So adverse childhood experiences is a set list of 10 items that measures a few different domains. It's basically bad things that happened when you were a kid. So that can mean your parents getting a divorce, physical abuse, a parent being incarcerated, certain stressors that we put on a scale of 10 items, which is here. And when administered to someone, you go through it, you say, did this happen to you, yes or no? The amount of yeses you said is your ACE score. So if I say, yes, my parents got divorced, yes, I experienced sexual abuse, go through it. As many of those things that I say yes to, that's my ACE score. Within the civilian community, we usually see around between 1 and 3 ACE scores is the most common figure. And so ACEs in the mental health community, even outside of veterans, we see significant correlation between higher ACE scores and higher problems later in life, including mental health, physical health, early death. This doesn't mean that being abused as a child means you're going to die of heart disease, but it means that people with higher ACE scores are at risk for all sorts of different things, even outside of just mental health. And so when we look at the veteran population, what we see is that our veterans are far more likely to have higher ACE scores than the general population. So this first little blurb is how many people have 0 ACE scores, the blue being the general population. So more than double civilians have 0 ACE scores compared to veterans. And then when we look on the latter side of the bar graph, we see that our veterans outflank the general population when it comes to these higher ACE scores. And what this translates to is devastating effects. Someone with an ACE score of 4+ is 1,200% more likely to attempt suicide than someone with an ACE score of 0. You are at significant risk of later substance abuse, depression, and other challenges because of a higher ACE score. So veterans have higher ACE scores and they have worse mental health outcomes. And we don't believe that's a coincidence. We think that veterans are more likely to have these higher ACE scores because a lot of the times the military provides really good opportunities. It can provide a college degree. It can give you opportunities that you might not have if you come from a poor background, if you come from an at-risk background. So this isn't about saying anything negative about veterans. It's just recognizing the reality that our veterans have much higher ACE scores and they're struggling later on. And what we hope this will bring about, recognizing ACE scores, is either both early screening and post-deployment screening. So screening when someone joins the military. This is not about disqualifying anybody from joining the military, but by recognizing existing challenges so that we can put support systems into place from the moment they join the military. And also post-deployment screening. So if a veteran comes into my office, I don't just want to talk to him about what happened when he was in the Middle East. I want to know about what happened when he was a child. I want to know about what he has been set up for in his most formative years. But standard treatment does not include screening for ACE scores. It includes screening for post-traumatic stress disorder from seeing bombs. But if you've been seeing bombs drop figuratively your entire life, that has significant consequences. So what we're hoping for is early detection and post-deployment screening for higher ACE scores so that we can offer more comprehensive and complete care for our veterans. And so through addressing moral injury and adverse childhood experiences, the goal is that we will be able to develop more holistic treatment approaches to veteran mental health. Instead of throwing darts at the wall, hoping we hit post-traumatic stress enough times that will somehow be able to lower the suicide rate that hasn't gone down in 20 years, we're hoping to develop more holistic treatment that targets all of the risk factors in a veteran's life, that offers them more comprehensive care to bring true treatment and healing. And so as I finish up, I just want to leave with 3 final messages. Firstly, for civilians and veterans, I ask that you keep the conversation around moral injury going. When I started, I asked how many of us had heard of it, and it was basically nobody. And that's because it's not being talked about. If the conversation around moral injury continues, we can advocate for change, we can improve programs, we can address this critical need. For civilians, I ask that you listen to the veterans in your life. For far too long, far too few people have had to hold the entire burden of war. The reality is when our country goes to war, we're all going to war. It's just a small portion of it, that portion of us that holds that disproportionate burden. So taking the time to listen to people, to truly showing interest in somebody's military service, to not just saying thank you for your service and forgetting about them, but truly showing that empathetic care. And finally, for veterans, I ask that you maintain hope. Hope that there is a community of people whose lives' work is improving this quality of care. Because for far too long, far too many veterans have struggled because of negligence, because of ignorance. But I just ask that you maintain hope that there are people that are truly working to improve this. So I just want to say thank you to everyone who has come by either in person or on the Zoom, and to all the veterans, thank you for your service. And before I completely wrap up, I will be at the Michigan Parkinson Foundation for the next few weeks. After that, I do want to leave the opportunity open. My contact information is on the screen. If you have any questions, if I can be of any support to you, if I can offer any resources, I'd be more than happy to do that while I'm still at MPF or into the future. So please feel free. But thank you.
Thank you, Anna. That was even better the second time that I've seen it. So It's so impressive, and I can't thank you enough for your dedication you're already showing to the veteran community. Um, and I too want to thank all the veterans as well. We had so many people interested in tonight's program from all of the branches of service, so thank you. Okay, well, we're going to move right along, and I get to introduce Dr. Dan Leventhal. He is the Assistant Professor of Neurology in the Movement Disorder Division at the University of Michigan. His primary clinical duties are at the VA in Ann Arbor, where he co-directs the Deep Brain Stimulation Program for movement disorders. His practice there focuses on the treatment of Parkinson's disease, tremor disorders, dystonia, and related syndromes. We are so fortunate to have Dr. Leventhal here tonight. He's been a wonderful friend and supporter of the Michigan Parkinson's Foundation and newest member of our medical advisory board. So I'll turn it over to you. Thank you.
All right. Let's see, is there a way to tell if Zoom can hear me?
Good question. Yeah, let me give a thumbs up.
We got a thumbs up? Okay, great. All right. Yeah, so I'm Dan Leventhal. I'm a neurologist at U of M and at the Ann Arbor VA. I've been told by various people at the VA that the VA is not allowed to endorse other organizations, so I guess I'm here in my capacity as a neurologist at the University of Michigan who happens to be talking about stuff that happens at the VA. So I'm not going to spend a lot of time talking about Parkinson's disease per se. I'm going to really focus on what the types of things that we have at the VA and a few things that are maybe a little more specific to veterans. And the main reason for that is that, as near as we can tell, biologically, there isn't much difference between Parkinson's disease if you're a veteran or Parkinson's disease if you're a civilian. And therapeutically, there's not much, right? I'm giving out the same pills at the VA and recommending the same therapies that they are down the street at University of Michigan or in Dr. Troche's office or Dr. Lewitt's office or Dr. Ellenbogen's office. There certainly are some unique risk factors among veterans, kind of unique risk factors among veterans, because unfortunately, lots of people get exposed to these things in one way, shape, or form. We'll talk about that a little bit. But the main thing I want to talk about is the resources that are available that you may or may not be aware of. And the main points are, first of all the VA benefits medically flow through the primary care provider's office. So if you have a primary care provider at the VA, then it makes it way, way easier to access the social workers that can help you get to the benefits that you've earned as a veteran. The second main point that I want you to take away from this, if you don't remember anything else, is that we are absolutely happy to see veterans and co-manage their Parkinson's disease with other neurologists. So if you come see us or you come see Dr. Halan at the VA at Detroit or anyone else in the VA, we are happy for you to keep your current neurologist. And I have some patients that so the outside neurologist is sort of driving the bus and we're just filling their prescription so they can use their pharmacy benefits. We have other patients where there's a neurologist much closer to them, but we're sort of driving the bus and the neurologist closer to them is sort of there if they really need someone there. So we sort of work with what we got. And the last point I want to make is that if you don't have a veteran service officer that you've been working with and you're interested in understanding what benefits you're eligible for, contact a veteran service officer, and I'll get to that in a bit. And then the last thing I want to do is thank Gretchen Glenn, who is the social worker and director of education at the Philadelphia Padrick. I'll tell you what a Padrick is in a second, because she gave about half my slide deck is from one of Gretchen's talks from February. So the VA in 2001 established the Padrick system, which is the Parkinson's Disease Research, Education, and Clinical Centers. There are 6 Padrick sites, and we'll see the map in a minute, and they're dedicated to caring for the, I got to be honest, the VA website has said 110,000 veterans with PD for like 5 to 10 years now, so it's probably much bigger than that, but that's the number that gets quoted. And the Padraics are basically dedicated to giving Parkinson's and other movement disorder specific care. So they're staffed by neurologists, but not just neurologists, but other healthcare providers, that specialize in Parkinson's disease. That might be psychiatrists, social workers, therapists, PTs, OTs, and probably pharmacists, people that I'm forgetting. And the 6 current centers of excellence are located basically on the coasts and in Houston. And so we sort of have this Padraic desert in the Midwest. The way these are organized is there's the National Parkinson's Disease Network. There's the 6 Padraics that are sort of the main centers. There's the Padraic associated sites. And then as of last year, they have the regional Parkinson's and movement disorder centers, of which Ann Arbor is one as of October of 2025. So this is our map. You can see the Padraics in red and their distribution on the coasts. They're sort of absent in flyover country, as the rest of the world calls us. Our parent Padraic is San Francisco for some reason. I don't know why our parent Padraic is San Francisco. So when I was a resident, if we had a patient at the VA that we recommended DBS for, they would fly to San Francisco, get their DBS, and then come back to the VA in Ann Arbor. And in fact, the reason we have a DBS program now is that Dr. Levin was a fellow learning how to do DBS implants at San Francisco. And she did an implant on one of the veterans from Ann Arbor and said, this is stupid. Came back to Ann Arbor and helped us start a DBS program at the Ann Arbor VA. So this is basically the Padraic mission in a nutshell. To provide clinical care, to provide education for both clinicians and for the general public, and then also to engage in research. So on the clinical side, it's basically all the stuff that you would expect at a full-service movement disorder center. So, certainly the DBS neurologists that are fellowship trained, but again, the physical therapist, the occupational therapist, the social workers, the pharmacists, the brain surgeons, can't forget the brain surgeons. See here, who am I forgetting in here? The palliative care specialists, speech therapy, all of those things are available at the Padraics, and all of those are available at the Ann Arbor VA. Another major point I want to make is that you don't necessarily have to travel to the VA, at least not every single time. So especially since the pandemic, we've made a really big push to do as much care as we can remotely to make it as accessible as possible. So we do new patient consults over the video. I have to be honest, it is not my favorite because I really like to be able to do a full neurologic exam before I tell someone that I think they have Parkinson's or don't have Parkinson's. But we can do it if people can't get to Ann Arbor or whatever the nearest VA is to you. Certainly, we do a lot of our routine follow-up care by video now. So for patients that are living up in northern Michigan or out in western Michigan, what we'll often do is we'll see them in person once a year and then do a video visit once a year, so they don't have to schlep to Ann Arbor all the time. The Padraics like to say they do DBS adjustments over video. I'm not a big fan of DBS adjustment over video, but we can do it. And we can video connect into pretty much anywhere. So for people that are comfortable using technology, we can do video visits right into the home. For people that aren't comfortable using technology, but maybe you live near a CBOC is a community-based outpatient clinic. So there's a CBOC in Toledo, in Jackson, in Flint, sort of all over the state. So people can go to their CBOC and do a video visit from the CBOC if they're not comfortable with it. The VA will provide devices for video visits and help try to get you appropriate internet access so that you can do a video visit if you don't have it. So we can do a lot over video now. So the travel isn't as bad as it used to be. So I should mention the slides with the U of M logo. Those are my slides, and basically everything else is from Gretchen. So you can see how much Gretchen contributed to this and saved me time. So in Michigan, obviously, I'm at the Ann Arbor VA. I'm most familiar with it. We have 5 movement disorder fellowship trained neurologists that see patients at the Ann Arbor VA. We have 3 movement disorder clinics every week. Dr. Heston, with whom I share a clinic, she does Botox injections at the VA. Dr. Heston and I program DBS, and we are in between doing DBS implants in Ann Arbor right now. The reason for that is that Dr. Levin, who started the DBS program in Ann Arbor, sadly left for Traverse City. So she's up in Traverse City, but we are on the cusp of getting a functional neurosurgeon back at the Ann Arbor VA. So why is that important? Well, that's important because there are a lot of veterans maybe that aren't coming to Ann Arbor for their care, and depending on their insurance situation, DBS could be very expensive. It is possible that sometimes we can do the implant in Ann Arbor. So I can think of several patients that are followed by outside neurologists. We saw them, we did their DBS surgery, and now they're back following with their neurologist, and for example, at Corewell in Grand Rapids or various other places. So we're happy to work with people to, whatever winds up working out best for the patient. The pharmacy assessment, so this is something that's new that we were able to fund because we got our movement disorder center status. So we have 2 pharmacists in our clinic now. So now when we make what used to frustrate me a lot is we'd make a med adjustment, and we'd see someone back in 6 months, and 6 months later, right, now we're finding out what happened with the adjustment we made 6 months ago, and it wasn't quite enough, or it was too much, and they were sort of out there in limbo and had a hard time getting in touch with us, or didn't try to get in touch with us. So our pharmacists will call now. So every time we make a med adjustment, the pharmacists call in 2 to 4 weeks. They follow up with the patient. If they're still adjusting things, the pharmacist can prescribe. So if there's, something's going wrong with their med, or the med wasn't quite enough, or we need to adjust the timing, we can do that more frequently now and much more easily. And of course, we have all the services we were talking about earlier. There's also physically at the Ann Arbor VA, there's a Parkinson's and movement disorders exercise class that I believe meets on Fridays. It's run by one of our physical therapists. There's also general neurology that's associated with the Ann Arbor VA at Canton and Toledo. So they're not movement disorders trained, but we have a few patients that see them and then maybe come up and see us for specialty care less frequently because it's more convenient that way. And as I mentioned earlier, we're also happy to coordinate with community providers. So just because you come to the VA doesn't mean you have to stop seeing the neurologist that you were seeing. And sometimes we're mostly just prescribing what they recommended, and that's fine as long as we're comfortable that it's safe. So for years, people were seeing Ted, my God, why am I blanking? Ted George at the Detroit VA. And so we have inherited some of his patients, especially some of his Botox and DBS patients now that he's in semi-retirement. And Dr. George's patients love Dr. George. So we have big shoes to fill when we're trying to see his patients. But Dr. Howland is still at the Detroit VA, I think. And so he's a movement disorder neurologist that does DBS and Botox. And I know that in terms of other just neurology care in Michigan, Robin Kazanowski is a nurse practitioner up in Saginaw. So she's not a Parkinson-specific provider, but we share a lot of patients with her, and we have a lot of patients that live up closer to Saginaw that will go see her and then see us by video or come down to see us less frequently. So this is not an exhaustive list of things that are available through the VA. Things that I want to emphasize. First of all, not an exhaustive list. Secondly, just because it's the VA doesn't necessarily mean it's free. There are complicated issues related to service connectedness and income levels, things. So not everyone just gets free care at the VA. It is generally much less expensive at the VA than it is outside the VA. But I don't want to give the impression that just everything's free. And everything flows through the primary care doctor. So when you enroll at the VA in VA healthcare, you have a primary care provider. All the services flow through that primary care provider's office, including the pharmacy benefits. So pharmacy benefits are, clearly a big thing in Parkinson's, right? So if you're taking Sinemet, I don't know what the street price of Sinemet is off the top of my head. It's not that much. If you're taking Crexont or Ritari or Vyalev, right? Those types of things start to get expensive, and many of those can be offset a lot by the VA. The second point I'm going to make about pharmacy benefits, and I want to make this point because I just saw a patient last week. Initial consultation said, my doctor said I should take Crexont, right? And I agree. Crexont is a very reasonable thing to help this person. So if you don't know, Crexont is sort of a fancy levodopa new fancy levodopa preparation, and it's on patent, so it's still expensive. But the VA has rules around non-formulary drugs. So eventually we will probably get to Crexont, but there are other things that we have to try first, and either they'll work, and that's great, or they won't work, and then they'll be Crexont eligible. And that's true for most of the sort of more expensive things. So I don't want to give the impression that you just sort of walk into the VA and everything's paid for. But everything is often a lot less expensive. Certainly mental health care at the VA is a big strong suit of the VA, especially with care more specific to veterans, PTSD, moral injury, as we just heard. I want to highlight the home-based primary care program is a really nice program where there's a nurse, physical therapist, occupational therapist come out to the home regularly. So for a lot of our patients that are having a hard time getting out, or they're at a distance, I don't know what radius of Ann Arbor they have to be within, or of their home VA they have to be within. But they will come out to the house, and then we get notifications, Mr. Smith is really struggling with his Sinemet, here's what's going on, how would you recommend adjusting it? Prosthetic equipment, so DME is durable medical equipment, so that's, lots of stuff that can end up being very expensive that the VA can get for people. So I'm not going to read this slide, but this is a home improvement grant that veterans may be eligible for. You can see the types of things that it can be used for. Generally, these types of improvements require someone from occupational therapy to come to the home, either virtually or in person, and say, yes, this is the thing that we need for safety, and then often the VA will approve it. These, I forgot to put the dollar amount on here. You can go to the link down below. It's a public link with all the information about it. I think these are on the order of $6,000 over a lifetime. And there are bigger ones for larger home improvements or even home purchase. These generally you have to be service connected. I'm going to get to what service connected means in a minute. There's all these, their requirements. You'd want to talk with a social worker and make sure you're eligible. But these are things that do exist for veterans. The iTele-OT, so this is the internet-based teleoccupational therapy. This is a program that also we were able to set up because of the Movement Disorder Center designation, so the Parkinson Center designation that we got last year. So this is run by Neil Alexander, who's a geriatrician at University of Michigan and at the VA. And so he has a couple of occupational therapists that specifically do occupational therapy through the internet. So they can do home safety assessments instead of having to have someone physically come out to your house. So this is good if you're outside of the radius for Ann Arbor or Detroit. or whatever the local VA is. But you can see what the requirements are to access that. So we'll use that commonly, for example, for people with bad tremor that we're looking at maybe adaptive utensils, things like that. They want to come all the way down to Ann Arbor for this visit, but we can get that done remotely. We also have virtual exercise programs. So this is also Dr. Alexander's baby. So there's a GeroFit class. There are both in-person and remote classes. And I think, Julia, can you email the presentation? And because some of the stuff in here has it has links, but not the address on the slide. So we can get those out. So again, you can see the requirements, but there are exercise classes that are a little more accessible. And we are in the process of, with Dr. Alexander, trying to design a more Parkinson specific. So right now, GeroFit is just get up and move, but we're working on developing more Parkinson-centric exercise programs that can be done virtually. All right, so that's sort of a very quick overview of some of the things that are available through the VA that you may be eligible for. On the education side from the PADRIC, so you can see the links up here. They're both patient education programs, also programs for healthcare professionals. So one of our fellows is going to speak in April for a Parkinson's disease 101 for basically primary care providers. For non-neurologists. And there are several support groups. A lot of these are virtual. Now the PADRICs, like I said, the PADRICs are on the coast and in Houston, but several of these are virtual. And I know in particular, we have several young onset Parkinson's patients that are really like a support group for the young onset Parkinson's. And I did not know until I got the slides from Gretchen that the VA has a young onset Parkinson's support group. And the information about who to contact is there in the middle. So the contacts are mostly either social workers or physician assistants at the different PADRIC sites. And of course, Julia already brought up the Michigan Parkinson Foundation Veteran Support Group, which we regularly tell people about in our own clinics. So Julia mentioned that people always ask about research. That's a really, really big topic. There are lots of things going on. Some of them are sponsored by the PADRIC. So for example, certainly the biggest study comparing different forms of DBS was done entirely inside the VA system. Which target works better? And the answer turns out they work about the same. There's all kinds of different studies that have gone on through the VA, many of them sponsored by the PADRIC. So some of the things that are going on right now at the national level, there's this CSAP study. So this is a study trying to understand whether a drug called quetiapine versus a drug called pimavanserin, which are used to treat psychosis in Parkinson's, hallucinations, which one's better, if either of them is better. This is a big national study that we've enrolled some patients at Ann Arbor for. Vet PD is a little bit like PD generations, but specifically for veterans. This one is a little bit more of a pain because you actually have to go to a vet PD site, and there are no vet PD sites in Michigan. I think the closest is Chicago. PD generations, I'm guessing that many of the people on this call know about PD generations, but if you don't, it's a national study, and they will basically do genetic testing for Parkinson's for free if you sign up with them. They will do the genetic counseling, and all these things. And so, for us as clinicians, this is wonderful, and as Parkinson's researchers, because this is one of the next big frontiers in Parkinson's disease, is really understanding how all the different genetic interactions influence Parkinson's, and the only way to get to that is to have lots of people where we know if they have a Parkinson's gene or not. PPMI, that's also probably one that this is not a veteran specific. So PD generations and PPMI are not veteran specific, but many of the VAs are participating in them. PPMI is the Parkinson's Progression Marker Initiative. So that's looking at the progression of Parkinson's over time. It requires a lot of visits. And then the Million Veterans Program is not a Parkinson's research program, but it is sort of like a gigantic veterans health study. So looking at genetic interactions and exposures and just basically trying to understand as well as they can over time what the risk factors are for different conditions. So you don't have to have Parkinson's to get into that one. The goal is really to just sort of have a large cohort of people where we're keeping track of everything and seeing what's associated with disease. In Ann Arbor specifically, we have several investigators that study Parkinson's. So Dr. Bonin has several studies trying to understand why some people with Parkinson's fall more than other people that have Parkinson's and what are the risk factors for that. Myself and Dr. Opry, who's a biomedical engineer at University of Michigan, we have a research program trying to improve deep brain stimulation, looking at different markers of when do we have the electrode in the right spot. And of course, University of Michigan has a whole bunch of research programs going on, and the links there get you to the different studies if you're interested in participating. All right, so how do you actually get into the VA? So the first thing is you got to be enrolled in the VA healthcare system. And so there's a bunch of numbers and links on here about how to get into the VA system. Once you have a primary care in the VA system, if you're in Ann Arbor, it's easy. You get referred to neurology, and if you have Parkinson's, you would come see one of us. But we now, we take referrals from sort of all over the region. So Northeast Indiana, Northwest Ohio, pretty much all of Michigan outside of Detroit, I think we're seeing pretty much everyone. So to be VA eligible, you have to have served on active duty and not received a dishonorable discharge. And once you start to get into the weeds in the gray areas about the reserves, then you want to look at the website and potentially talk to a VA social worker or a veteran service officer and figure out exactly what you are and are not eligible for. So inside the VA, there's this lingo, service-connected versus not service-connected. And the idea is simple, the implementation is complicated. The idea is if your disease is related to your military service, you are service-connected. Or if the condition was exacerbated by your military service, you are service-connected. If your condition was not related to your military service, that is not service-connected. And that changes the benefits that you're eligible for. And the formulas for this are complicated, and they need a lot of help with navigation. And what I always tell my patients is that if I make a diagnosis of Parkinson's, the first thing you should do is you should contact a veteran service officer and find out if there are additional benefits that are available to you because of your diagnosis of Parkinson's disease. And then we will work with them to figure out and to provide whatever supporting documentation that we need to provide. Importantly, Parkinson's is a presumptively service-connected condition under certain conditions, which I'm going to get to in one slide. So what that means is that you don't need me or one of my colleagues to write a letter saying, well, Mr. Smith was exposed to jet fuel in whatever year, and there's this study over here that says maybe there's a link, right? For some exposures, you're just connected. And this is what they are. They are Agent Orange, Camp Lejeune, which we heard about earlier, and moderate to severe traumatic brain injury. So, which of course leads to the question, what is a moderate to severe traumatic brain injury, right? So you can't have just, bonked your head getting into the car. It has to have been something that for at least several hours caused some sort of alteration of consciousness. I looked, I could not find exactly how they define moderate traumatic brain injury. So I think that floats a little bit. Yeah, I'm going to get in a little more specific. So I'm not going to spend, I certainly don't want to spend a bunch of time presenting data, but I thought it's worth looking at one example, and that's the Camp Lejeune example. And the reason it's worth looking at the example is because what I think a lot of times what we don't think about is how do you tell if exposure X causes disease Y? And it's a really hard problem to figure out. So this is actually published in 2023. This is actually well after the VA already decided that you are presumptively service-connected for Parkinson's if you were stationed at Camp Lejeune for 3 or 6 months between 1950-something and 1985, or I think it's 85. So this is a study where they took 170,000 veterans based on their records from camp that were stationed at Camp Lejeune, and about 170,000 that were stationed at Camp Pendleton in California. And they said, if you were there between 1975 and 1985, how likely are you to get Parkinson's? And the answer is you are about 1.7 times more likely to get Parkinson's if you were at Camp Lejeune during those years than if you were at Camp Pendleton. So it's a pretty nice study because they're comparing, a pretty similar group of people in terms of age, right? It's not like these are all California kids, right? They could be at Camp Pendleton, but they grew up anywhere. They could be at Camp Lejeune, but they grew up anywhere. And there's this chemical trichloroethylene, which is an industrial solvent that, for whatever reason, was in the groundwater near Camp Lejeune. But if you break it down and you actually say, well, how many people actually got Parkinson's disease? Well, at Camp Lejeune, it was 0.33% of the people they looked at got Parkinson's, and 0.21% got it at Camp Pendleton. So if you take the 0.33 divided by the 0.21, that about gives you the 1.7 increased risk. So you could look at that and say, that's not a hugely increased risk, but it's a hugely increased risk if you're one of that 0.12 that got Parkinson's that otherwise wouldn't have gotten Parkinson's. And this is sort of a relatively easy study because they had all the medical records from the VA and from Medicare to go through for this. So proving these associations is really hard, which brings me to my next slide, which is that for a lot of the things that the PACT Act in 2024, I think? 2024, thank you. I knew it was in there, but I couldn't remember the exact year. Parkinson's is not on the list for those things. So it's not a presumptive diagnosis for example, burn pit exposure, at least not as of 2026, it's not. Now, as I understand it, that doesn't mean that you might not be able to get service connected for it, but what it means is that you're not automatically service connected for it. The PACT Act did expand some of the Agent Orange presumptive locations, though. So that may have changed some people's service connectedness, and again, there's a link there. So applying for the benefits. So one important distinction is the Veteran Benefits Administration is not the Veterans Healthcare System. So the Veterans Benefits Administration determines what benefits you get, but the Veterans Healthcare Administration is what provides the healthcare based on those benefits. And what I always tell you, the way to sort this out is either a VA social worker, especially if you're already inside the VA system. The veteran service officers are great. So I thought up until I gave this talk that the veteran service officers were employed by the VA. They are not. They're a totally separate group of people that have undergone training about VA benefits. A lot of them work for VFW, various different organizations. At the Ann Arbor VA, though, they have a place where the VSOs sit, so that if someone leaves my clinic, I'll often tell them, you should go down and see the VSOs. We just diagnosed Parkinson's disease, and you should go find out what you're eligible for. And they're great. And sometimes they're really annoying because they keep sending these emails over and over again saying, you need to write a letter for Mr. Smith because we've got to get on this and get his claim processed. But they are tenacious, and they really do advocate for the veterans to the point of really making sure that we do what we're supposed to be doing. And there is a National Patrick Hotline. I'm going to be honest, I've never called the National Patrick Hotline, but I know that the people that I've worked with and been on calls with at the Padraics are all very dedicated. And then the last bit is a little bit of propaganda for the National Parkinson's Foundation. We have a lot of their literature now in our office, which is really nice. We don't have to come up with our own. They have really nice brochures, lots of great information about Parkinson's, as I'm sure many of you are aware, with especially specific resources for veterans. And then this is probably the money slide, though. So this is Gretchen's list of links to things that are useful, like how to find a VSO if you're not sure how to get in touch with one. But this is why I think we need to share the presentation, because the addresses aren't on there. So the main things that I hope that you take away from this is that there are a lot of benefits out there for veterans that served our country. And we are happy to help you take advantage of them, even if we are not your primary neurologist. So that may be that we can get you your meds at much less cost than you would otherwise have to buy them. It may be that we can get you a scooter through the VA, or a home improvement through the VA. And we are absolutely happy to work with people outside the VA. Our only requirement is that, we want to make sure people are safe, right? So we're not just going to blindly prescribe things, right? We want to see people, make sure that we're like, okay, this sounds like a reasonable plan. Sometimes we'll make our own little tweaks if things aren't going well. And we've been working on expanding our access, and hopefully now that the federal hiring freezes have been lifted, we'll be able to take some more of this, take some more of the Padraic funding and use that to really expand our care and make access easier. And with that, let's say these are the people I work with. On the left, that's most of our movement disorders team at U of M. The guys in the red circles are VA neurologists as well. And I have the pleasure of working with Dr. Heston on the top left there in our clinic on Thursday morning, where we see most of the DBS patients. She does the Botox. And Dr. Heston, Dr. Kodegal, and Dr. Bonin share a clinic on Friday mornings as well. And with that, I will stop.
Wow, thank you so much. We're happy to answer any questions. If anybody has any, we are monitoring our Zoom. So I do have a question for you myself, if I can kick it off. Given the what's happening now with the shortage of funding for Parkinson's research, how has that impacted the VA, if any, or we don't know yet?
So I can say from personal experience, so there's a couple questions there. So one is research funding. Research funding is just tight everywhere. Research is getting cut a lot. Grants that would have been funded recently they're just below the line now. So there's a lot of good science being left on the table, and I feel like some of that is mine, but yeah. Practically, we've had a lot of impact in the VA because of the federal hiring freeze. So we got funding from the Padraic, but then we couldn't use it to actually hire people. So that's starting to loosen up a bit now. So we're hoping to hire a physician assistant that will be able to make our clinics much more accessible, which we were hoping to do a while ago. So yeah, the funding cuts have definitely hit us. And the second part of that is because no other departments could hire. When we go to say, like, could we purchase the time of a physical therapist to come and be in our clinic? Well, we can't, because there's only so many physical therapists, right? So, and they're working at capacity. So it sort of all trickles. So yes.
Yeah, you can tell it's a trickle down effect for sure. And unfortunate because I mean, this was very impressive, all the services that are available now at the VA. I'm a little embarrassed to say I remember those DBS days when we shipped them off to San Francisco. Um, so it has definitely come a long way, and that's great. Especially all of the supportive services through Allied Health and things like that. So I definitely will share the, this program's being recorded. It will be uploaded to our YouTube channel, and I will email everyone out who registered a copy of the slides. Are there any other questions that anyone has? Yes, I'm coming with a microphone so everybody can hear.
I specifically work with home health support. So we specifically work with HHA and respite with the VA. And I've got a couple of questions. So when I go and meet with families, specifically with veterans, we always get them started in the process of applying for those. So they're either already in the, they've already seen a VA doctor or they have not. What would be best practice for those who don't have a VA doctor or they've not seen a VA doctor? Like I remember signing up a family and he had gotten hearing aids back in the 80s for a VA doctor. So he had to go and restart the whole process again. But specifically with people who are living with Parkinson's, um, should I still connect them with the VSO? I mean, we kind of coach them through the process. This is the number that you call. And specifically with people who are living, our veterans who are living with Parkinson's, should we just go ahead and recommend that they register with the Ann Arbor VA because of this incredible program that you all have there?
Yeah. So what I say is they just need a primary care provider.
Right.
So once they get a primary care provider, and if their primary care providers in Detroit or any of the VAs around here, they can then get to Ann Arbor. And if it's really difficult for them to get to Ann Arbor, but they want to see a movement disorder specialist inside the VA, then like I said, we can often arrange that over video. And then if we do the video and we feel like, we just can't really figure out what we're supposed to do next, we really need an in-person exam, then we'll try and figure out how to get them to Ann Arbor. But I wouldn't, if you live in, I don't know, Oakland County or Lansing and it doesn't make sense to come to Ann Arbor and have a primary care doctor. I mean, there are other things that get a little wonky inside the VA system about who's paying for which piece of equipment, but we get there. So the main thing is just get in the system, get a primary care provider, get the primary care provider to get a referral to us, and then we'll figure it out.
Okay. Very good. Thank you.
I just want to remind the audience that if you have a question, you can unmute yourself and ask it. I thought it was very interesting about the VSOs. You can tell that maybe those are an integral part of assistance for people. Oh, we have another question.
This question's for Anna. For any service providers that might be on the line, do you have just like a really quick what to say and what not to say to veterans? I found that really helpful in talks I've heard you say in the past.
Okay, now I can be heard. So I guess my first piece of advice would be to ask questions, to listen to the veteran when they're talking to you. A lot of the times you don't need to do a lot of the probing. My number one suggestion would be don't ask something stupid. Don't ask, did you kill somebody? Don't ask anything overly invasive that's not appropriate. But starting with general questions, what branch were you in? What job did you have in the military? Questions like that are often all you need to kind of open that door to have that veteran describe their story in the way that they want to, that they feel comfortable with. I would also recommend not, as I said in the presentation, not assuming any challenges. I've heard that veterans are often very uncomfortable with how insistently they're screened for suicide when there was no reason to assume that in the first place. So not assuming that they're divorced, not assuming that they're suicidal, not assuming they have post-traumatic stress disorder, not making those preliminary assumptions based off of someone being a veteran, and actually listening to them when they're talking to you so that you can just fully assess what the situation is. I guess those are the first things that come to mind, as well as just maintaining humility in that respect. I think it's really important to not assume you understand. I never want to be speaking to a veteran and say, oh, I understand, because I don't. I might have seen pictures, I might have seen videos, I might have read about it, but I was never at boot camp. I was never in Fallujah. I was never in Vietnam. So just letting the veterans speak for themselves in the way that they feel is appropriate, while maintaining respect for their service by having a baseline knowledge of the military, but not necessarily assuming that you understand everything because you know a little bit about it.
Thank you. Thank you so much, Anna. I think you might have answered this question, but just to clarify again, we had someone ask how they can get assigned to get a movement disorder neurologist at the VA. And I'm pretty sure I understood it that they need to see a primary care doctor through the VA first. That's the first step, correct? Okay, wonderful. Well, with that, I think we are ready to wrap up this incredibly knowledge-packed program. I want to thank our speakers. Anna, that was fabulous. Of course, Dr. Leventhal, we appreciate it. We really appreciate it and are grateful for all of our veterans and continue to think of you. And just know that you're not alone. No one is alone. And we are available at the Michigan Parkinson's Foundation. You can contact us through our website, our telephone number, even our social media. So with that, thank you, everyone.